after it, and then
I was.
Why do we keep getting random documents?
My mom got Johnson & Johnson.
What's that for?
She apparently had some interesting side effects. She's still constantly cold.
really?
Yeah.
Well, lucky. Okay, so ultrasound. You will have. I will tell you about this test.
Yeah, what is this?
This is escalating.
Excuse me.
What is this? I have so many questions.
This examination
Yeah,
of sorts.
it's escalating.
Excuse me.
There's gotta
What
be
is the
a way to
seven-letter?
describe it.
What does the seven-letter word on the outside of this building say? College. I'm gonna have to tell you what's on the test.
No, I'm just.
It's everything. It's a test.
Information about it.
Yeah.
Oh, you're gonna be asked questions on this
Advanced heads
test that we have been tested on already. So all the material. Because I want it in your own words. So there may be a question about a wound. There may be a question about. There's certainly going to be questions about pain because you haven't been tested about pain theory, Mills-Echo wall, etc. And there's going to be some questions about ultrasound and maybe very little about electricity. But okay, so you should know it all, especially because you all did so wonderfully on that first exam.
Oh yeah.
No, not me.
I get a sense of sarcasm.
All right, and there is a sense of sarcasm. So I can do that. I'm the boss.
So ultrasound.
Yeah, so certainly all about ultrasound. And Professor D'Onofrio, we put together some questions, clinical questions, and he thought, did you send
They
me?
have it, yes.
Okay. So he sent you some questions about ultrasound, and those of you who want to stay between classes to discuss it can. And I don't know about his availability or your availability after class, but also you can start reviewing that because it'll give you a basis on what modes of transmission are associated with ultrasound, frequencies, etc. Regarding treatment. And we talked about a frequency of 3 megahertz as opposed to 1 megahertz, and we said 1 megahertz would penetrate how deep? 5 centimeters, 3 to 5 centimeters, and 3 megahertz would be 1 to 2. And we also said that when you have a frequency of 3 megahertz, what do you do with your intensities? Is it less or greater than one that you use with 1 megahertz?
1 megahertz? Less.
It's less. Why is it less? Because ultrasound becomes absorbed and the skin becomes warmer. So your frequency and the absorption is inversely proportional with that frequency that we said. So the greater the frequency, 3 megahertz will be absorbed more superficially than 1, right? So maybe a 0.5 watts per centimeter squared. What's the difference between watts per centimeter squared and watts? What's watts?
Power.
Watts is power. So if I give you 20 watts and say I want you to deliver 2 watts per centimeter squared, what's the size of the transducer? 10. Okay, good. What's the difference between thermal and non-thermal? Or continuous and pulsed? Isaiah, what's the difference between continuous and pulsed? I can't hear you when you talk like that. Talk louder. What's the difference between continuous and pulsed?
Continuous is, as its name suggests, it continues on. It doesn't stop. While pulse is more of like kind of like a tapping. It goes and it stops and it goes and it stops, kind of like that.
Continuous is also thermal.
Continuous is on all the time, right? Pulse, you said it stops, then it comes back on. Anything else?
I believe that continuous generates more heat than I would say. It's more kind of like surface level.
What generates more heat?
I would say continuous.
You would say continuous? Why?
Because like it says, that if it continues to go and it's not like stopping or anything, of course it will generate more heat that way.
Okay, so what do you have to adjust on a machine if you're looking to do a pulse ultrasound?
If you're looking to do a pulse ultrasound, you would have to, I would say like, frequency depending on how deep you want to
Has
go.
nothing to do with frequency. What do you have to adjust on a machine when you do pulse ultrasound?
Intensity,
Hmm?
intensity,
Has nothing to do with intensity. What do you have to adjust on the machine when you use pulse ultrasound?
Duty cycle.
Duty cycle?
Yeah.
The duty cycle. The duty cycle. Put your hand up. So duty cycle. So if you say duty cycle, Dave, what duty cycles are available on the machines you looked at?
Wasn't it like 10 to
10,
150?
20, 50.
10 to 150, wasn't it? And then we had to,
10 and what?
was it 10 and
10, 50, 90?
10,
What
20,
machines did
50.
you look at?
I don't remember.
80?
20,
The Excel Ultra 2?
So 10, 20, and 50? Okay, so what does that mean, Dave? What's 10% duty cycle?
Isn't that the pulse duration is on for 10% of
10% or, let's say 10 seconds.
10 seconds? Okay, so it would be on,
So if you have a 10-second span, then the ultrasound would be on continuous, and you have a 10% duty cycle, how many seconds is that on?
1.
So what would you use 10% for as opposed to 50%?
Okay.
Like
Acute?
Acute epicondylitis.
Wouldn't you use both for acute?
Acute patient.
You don't want to increase the inflammation.
Wouldn't you use both for acute?
It's non-thermal.
It's non-thermal, wouldn't you use both for acute? So what's the difference
No.
between 10 and 50?
For the amount of time that,
It has nothing to do with time. What's the difference between 10 and 50? 50% duty cycle as opposed to 10% duty cycle. What's the difference?
Instead of a tenth of the time, it'd be half the time.
the amount of,
But what's the difference in what kind of a patient you would use it on? Because would you use 10% and 50% on a person that has acute problems? Yeah.
Yeah.
But what do you have to know?
How acute it is.
Who's more acute, right? So if you're telling somebody to use ice 3 times a day because they're in agony and they have a great deal of inflammation, then you would use a 10% duty cycle. But somebody who starts to get better and they're still acute though, they still have the acute inflammatory signs, then maybe you can go up to 50%. All right, you have to use what you have here. Yes, Christopher? What do you want?
some enlightenment.
That I can't provide.
How much time you got?
Pulse frequency versus duty cycle. Are those the same thing? Pulse frequency?
No, don't worry about pulse frequency, you're not gonna adjust it in the machine, just leave it as is.
Okay, so what is pulse frequency?
Pulse frequency is just the frequency of the pulse, but it's not the duty cycle.
No.
Yeah. Don't worry about it, that's done by the manufacturer.
Very good.
Okay. So electricity. All right, we already know this. We already know that electricity is charged particles, and we have ions or electrons that are the charged particles associated with electricity. And we also know that electricity follows the path of least resistance, right? So we have to know about resistance. That's what we'll talk about Ohm's law. And we know that the movement is from a higher concentration to a lower concentration. And we also know that the more that the ions are going to move, with the additional movement of the ionic movement, the more energy that's dispersed across the cells. So when we talk about Ohm's law, I equals V over R. I is the electrical, is the intensity or the electrical activity. And that's directly proportional, since it's I equals V over R, it's directly proportional to the voltage, but it's inversely proportional to the resistance. So what does this mean, and how does it affect us? So if you're going to have greater resistance, because I equals V over R, then what are we going to have to do with the intensity to overcome the resistance? Hello?
Increase the
What are we gonna have to do with the intensity to overcome the resistance? This side. Cindy? Rodneil? What are we gonna have to do? Don't tell me to repeat the question, I said it twice. What are we gonna have to do? If the intensity equals V over R and it's directly proportional to the voltage and inversely proportional to the resistance, and we have greater resistance, what are we gonna have to do with the intensity? Increase it. Increase it. So is this a good thing when we talk about electrical stimulation? Because increasing the resistance may make it uncomfortable for the patient. Increasing the intensity, I'm sorry, may make it uncomfortable for the patient. So when we encounter resistance in a patient, we refer to it as impedance. Those words are used interchangeably, resistance and impedance. So what's offering the impedance to current flow? What are some things that could offer impedance to current flow?
Fluid content, like fluids, the skin,
The skin, right?
contact,
What else?
like fluid within the joint capsule.
Fluid, yeah. So edema, yeah. What else?
Adipose tissue? Adipose tissue?
Say that again?
It's an adipose tissue.
Adipose tissue? Okay. Anything else?
Location,
Body hair.
Location?
connectivity.
Body
of the
hair.
actual electrodes.
Creams? Electrodes that are not appropriately
Attached or sticky.
wet or appropriately buffered, right? So all this stuff can provide resistance to current flow. So we have to know this. So if we're treating somebody like Professor D'Onofrio, and we're treating his lateral epicondyle, and we need to use an iontophoresis, let's say, which is a DC current, which is very caustic, which we haven't talked about yet, what might I have to do to his lateral epicondyle before I apply the electrodes? Shave it. Shave it. Okay? Because I'll have to turn the intensity up so great that it might feel uncomfortable. Right? And then I won't be able to provide him with the treatment. So, I need to adjust that. All right, so flow of the current equals the push of current, or the voltage of the current, divided by or over the resistance to current flow. That's I equals V over R. That's Ohm's law. All right, so it says, meanwhile, the rest of the world is developing nanotechnology. What is implied by this formula, John? Current varies directly with voltage and indirectly with resistance. When will I ever need this? Says, let's say, Chris is A. He's the one that's sitting there saying current varies directly with voltage. When will I ever
He's
need
asking
this?
that.
That's,
No, he's definitely asking.
that's Devin. When will I ever need this? That's Devin.
And the last
And
one, Steven.
Yeah, thank you.
which one is? Who wants to say that's them?
That's Steven.
Steven? Okay.
Steven's
All right.
whose point is it? Just take it.
So, an imbalance in energy is a charge. Now, charge equals current over time. When is a charge important? Is a charge important when you have alternating current? When is alternating current? Remember I said we have a positive and we have a negative polarity, and we have a line. If I had a board, I could draw it. And we have an AC current where you have a symmetrical waveform above and below the line. There's no net charge associated with this. There's no net current charge buildup in the tissues because it's alternating. So we have an above and below, and I'll show you a graphic representation of it. But when is it important? It's important when we have to choose a negative or a positive polarity for treatment. Okay, so that's important with a DC current, direct current. So we're choosing whether we chose a positive polarity or a negative polarity. And one of the DC currents we use is iontophoresis. And iontophoresis is delivery of a drug via an electrical current. Okay, so delivering a drug. We also use a DC current if we're working with a muscle that's denervated. Okay, So a muscle that's denervated, meaning it doesn't have a nerve supply, or the nerve supply, there's a problem with it. We also use DC current with wound healing. Okay, so if we have an inflamed wound that's infected, we can use a negative current, negative polarity. If we use, and basically, if you remember this, you'll be pretty good. When we use negative and positive polarities, as a rule, we can say negative for edema and positive for pain. Okay, so if we see some tissue that has edema, we can use a negative polarity. Because when we talk about charges, what do we know about charges? It's kind of like when you date, when you go online. And some of you are online right now, looking at these pictures that have been photoshopped. What happens with positive and negative polarity? Opposites attract, right? Positives repel. Yes? That's the same thing with charges. Opposites attract, positives repel. So if I wanted to repel edema from an area, and I'm telling you that I use a negative or a cathode over that area, or a negative electrode, then what polarity is the edema? Opposites attract and positives repel. Right, so what is the edema? What polarity is the edema? Negative. Negative. You got that?
Yep.
Okay.
Negative
Yeah.
edema, positive pain.
Question? No? All right.
So if we want to repel that edema away,
Yeah, actually, I'm getting flashbacks, I'm gonna yell.
Because opposites attract and positives repel. So if the edema is negative, you want to use the negative. Okay. So if I wanted to do iontophoresis on Professor D'Onofrio's lateral epicondylitis, and I wanted to use an anti-inflammatory cream that had a positive polarity, what electrode would I have to use? Would the electrode be positive or negative? I'm sorry. Yes, because the cream would be, let's say that's what I would have to tell you first. Let's say I was using a cream that had a positive polarity, a medicine that had a positive polarity. What electrode would I use, the positive or the negative?
Positive. To repel it through the tissue.
You're using a positive polarity.
Positive, because I want to drive it into the skin, don't I?
Yeah, I mean,
So if it's a positive medication, I want to use a positive electrode, because I want to push it away from the electrode, pushing you away, right? So I want to, like opposites attract and likes repel, yes? Okay. So what do I use? So let's get back to this, because I did mention DC current. DC current is the use of iontophoresis via drug delivery transdermally, using electrical stimulation, as opposed to phonophoresis. What's phonophoresis? It's transdermal delivery of drug also, right? But by using what? Ultrasound. Ultrasound. So here we're going to use electric stim. So this transdermal drug delivery via an electrical current is iontophoresis. That's using a DC current. What else did I say you use a DC current for? Denervated muscle, as well, denervated muscle, as well as wound care. Now, it's a good time also to talk to you about the difference, because when we talk about electricity, we talk about neuromuscular electrical stimulation, and we use other terms like electrical stimulation. So neuromuscular electrical stimulation, we've done a little of this in class. We tried to do a strength duration curve. We tried to look at what fires first, etc. And we looked at frequencies and we looked at pulse duration. What is a frequency? What's frequency?
how often something occurs.
Frequencies are represented in what unit? Hertz, right? And what's a frequency? Cycle per second, right? Cycle per second. That's the definition of frequency. What's a wavelength?
Different trillion
It's the distance between the waves, which you can look at with the frequencies, right? So the greater the frequency, does the wavelength become longer or shorter? Shorter. The less the frequency, the longer the wavelength. The longer the wavelength, the greater the penetration, the less the wavelength, the smaller the penetration, right? All this making sense a little bit, because you've read it 3 times, hopefully?
Yes.
Okay, so when we use neuromuscular electrical stimulation, and the nerve is intact, generally our parameters, and we could also use it functionally. If we use it functionally, it's known as FES, functional electric stimulation. So it's a little functional unit that we might put on a person's leg as they're walking, and we have a scheduled time on, time off. Can anybody give me an example of when they think that might be necessary?
Quad lag,
For ambulation.
toe drop,
How about weakness of the dorsiflexors?
toe drop.
Right, so if I'm gonna ambulate, maybe I have a time on where it kicks in and makes which is the dorsiflexor we want?
Anterior tip.
Anterior tib, thank you, Joe. Anterior tib, turn the anterior tib on, turn it off, right? Especially at heel strike, we haven't talked about it, but when we first strike our heel, and if we don't have strength of the dorsiflexors, what happens? My foot slaps on the ground. Right? Okay. So generally, when we talk about pulse durations and we talk about frequencies, our frequencies, and we did this again in lab, our frequencies change depending on what kind of stimulation we want. So does anybody remember from lab the other day? Not all of you did this, but what requires, what frequency is required to get a little response? Movement, a twitch response. What frequency is required to get a twitch response? You guys weren't there. Anybody?
It was 15.
Andrew? To get a twitch response?
Relatively, I don't know the numbers, but it's relatively low.
Relatively low. Yes, and it is low. Frequency to get a twitch response is only 10 to 20 hertz. Okay. Anything over 30, like 30 to 50, and generally we say 50, but you know, some of these machines, the way they're made today, it's between 30 and 50, but we say 50 hertz. That's the number I usually give you. Is associated with what kind of response? So I'm doing, or I'm doing, what's that going to do to the muscle? This is going to cause the muscle to do this, right? What's this going to cause the muscle to do?
Just continuously contract.
A tetanic or tetany. Tetany.
Isn't it 50 or higher?
Okay? That's the difference between me taking you and just shooting you. Boom. Or using a machine gun. Right?
Noted.
That's a good example.
Okay?
No.
Can it be before Wednesday?
So the other thing that is associated with current flow is the pulse duration. So, and these pulse durations on these machines, and they go anywhere from 150 to 350 microseconds. Okay. So what do you think you would have to set it for a person that has a large muscle, like a quad that you want to stimulate? More microseconds or less microseconds? Greater. All right, because the pulse duration is the time the current is on. So we want a greater pulse duration for a larger muscle. So you have to have at least 250 to 350 microseconds in order to stimulate a quad. Upper extremity, you could have 150 to 250. Sometimes they're just set in the machine and you don't change them. However, if you have a denervated muscle, you cannot use a stimulator that has microseconds in their pulse duration. You have to use something that is milliseconds. Okay? So you have to use a whole lot more pulse duration to get a response. You're not going to get a response in just a normal stimulator. Okay?
Professor, you started talking about neuromuscular electrical stim,
I'm sorry?
and you started talking about neuromuscular electrical stim.
Yes, neuromuscular stim.
And then you stated if the nerve is intact, and
If
you started
that's,
talking.
if the nerve is intact, we use neuromuscular stim.
Uh,
If the nerve is not intact, we use something called electrical, what's it called in your book? EMS, electrical muscle stimulation. All right? I just want to make that difference because I never really made that difference before, but looking in your book, it says electrical muscle stimulation as opposed to neuromuscular electrical stimulation. So if it just in case it's on the state boards. But that parameter, I mean, that question probably won't be, but it might say, if you have a denervated muscle, what needs to change? Frequency, duration, intensity, etc. It's definitely the duration, pulse duration. Okay. Needs to be on for a larger amount of time, or a larger amount of current flow needs to be used in order to get a response. Okay, so we just talked about the positive and negative polarity. And we talked about opposites attract and likes repel. You guys good on that, right? So a charge. What is a charge? Membranes at a resting potential. When is the membrane at its resting potential? When the sodium is outside and the potassium is inside. Okay, that's a normal resting potential. We have the sodium-potassium pump. So as the sodium starts to move in, then the cell will depolarize. The depolarization is also associated with an action potential. Okay. Then the potassium will move in, causing the cell to repolarize. So that's the whole thing about the sodium-potassium pump. Okay. And we have to have a depolarization in order for an action. You have to have that flow. You have to have that sodium moving in order to cause that action potential. Okay? And modalities can help do that. So they can help depolarize the nerve. So here's an action potential, and it talks to you about just what I said, the sodium-potassium pump. Okay? You could read that. But basically, that's all I want you to know.
Which one specifically?
So, current is the rate of flow of the electricity. And remember I said that depends on how much you're driving in, so the voltage as well as the resistance. So it's equal to the voltage, but inversely proportional to the resistance. Amperes are what measure flow. And the therapeutic flow is measured in milliamps, this terminology that we're using for E-stim. And the voltage is what is the force that makes it flow. So it helps provide the electrical current. We have a machine, we used to use low voltage, but now we use a lot of high voltage. High voltage is anything that's greater than 150 volts, and low voltage is anything less than 150 volts. And we have what's known as a high volt pulsed HVPC, high volt pulse current, that we use for wound healing and we also use for pain. Okay. Ohms or resistance is the impedance. So ohms or resistance determines the ease or difficulty of flow. Right? Resistance will give you will put up a wall, making flow more difficult. If you have less resistance, you have greater flow. This is just some terminology. Conductor allows the fluid, allows material to flow. So a metal's a good conductor, right? That's why we take metal off when we use electricity, because we don't want it where we don't want it. Okay, we don't want the electricity where we don't want it. Conductance is the ease at which the current will flow, and anything polarized has a good charge. So water, and if you don't believe me, stand with a lightning or a kite when it starts to lightning. Okay, so water, moisty, metal, the body, all that stuff is good for flow. And insulators resist flow. So So insulators like air, wood, glass, plastic, porcelain, rubber, fat, adipose tissue, skin, they all are resistant to flow. So how do we, opposition to current flow is the resistance to current flow. So how do we minimize resistance when we're working with a patient? We said before, we keep the area clean. If the person has any kind of a cream on them, we're going to make sure that we wipe off the cream, because a lot of people come in and say, my skin is very dry and I use a lot of hydration, a lot of cream. So that's going to provide a resistance to flow. Hair is going to provide a resistance to flow. Cologne, deodorant, all this stuff is going to provide a resistance to flow. The air electrode interface, what does that mean? That means that the electrodes have to be close to the skin, because if they're not close to the skin, they provide a resistance to flow. You know yourself. You have placed electrode on somebody and you've walked away, and I'll give you a good example. If you're lying on your stomach and somebody puts 2 electrodes on your back, and they just put tape on your back, and then 5 minutes later they come back with a hot pack, and they place the hot pack over the electrodes. What's the patient going to do? They're going to jump, right? Because now they're going to get better conduction. So we've decreased the interface between the electrode and the person. Clean the skin. The shortest pathway for energy flow. What's the shortest pathway for energy flow? We looked at this the other day in some people, and we said, oh, when we did the ultrasound combination, ultrasound E-stim, what happened, Kyle? We did you, right? What happened? So there were times when you really went, oh, and there were other times when it didn't move at all. So what were we stimulating? A motor point. So that provides decreased resistance to current flow, trigger points as well as motor points. And a motor point is that area of the skin that's closest to it's usually in the belly of the muscle, closest to the skin that can be activated with the least amount of electricity or electrical current. Okay? All right. As well as, somebody have a question? Yeah.
No, I was just gonna ask, is that because it's closest to the nerves that are underlying?
Yes.
The nerve?
Yes. It's anatomy. Yes. All right. If resistance increases, more voltage will be needed to get the same current flow. So therefore, do you think you want to put it over a bone? No, because bone will provide a lot of resistance, right? You're going to have to turn that current up, and it's going to really be uncomfortable. And it's not used for bones anyway. All right, clinical application. For excitable nerves, we're going to use it for nerves, muscle fibers, blood cells, cell membranes, things that are non-excitable are bone, cartilage, tendons, and ligaments. Okay. Now we're going to talk about some specific parameters, stimulation parameters. What's the amplitude? It's the intensity of the current. It's the strength of the current. Okay, that's the amplitude. It's associated with the depth of penetration. The deeper the penetration, the more muscle fiber recruitment possible. Okay. So, with electric stimulation, though, the electric stimulation actually controls the fibers that are recruited. When we volitionally contract a muscle, we contract every fiber, fast and slow twitch. When we use electrical stimulation, it selectively stimulates the fast twitch fibers. Okay, so if it's selectively stimulating the fast twitch fibers, what do we have to worry about? We have slow twitch and fast twitch. Which fibers fatigue more quickly? Slow or fast twitch fibers?
Fast twitch.
Fast twitch fibers. So what do we have to worry about when we use the electrical stimulation if they just selectively stimulate fast twitch fibers? Muscle fatigue. Muscle fatigue. So what do we have to do? It looks very good. So what do we have to do to the electrical stimulation in order to do muscle re-education? Do we leave it on all the time? We need to interrupt the current, right? Otherwise, if we leave it all on all the time, what will happen? The muscle will fatigue, and will that provide muscle re-education? No. So we need to modify the time on, time off. So we need to introduce a what? Just like we did in ultrasound, we had a duty cycle, right? So to speak. So we have to have a time on and time off. And generally, when we do muscle re-education, we need to have at least 10 good contractions during that treatment time. 10 good contractions. Anything more than this might fatigue the muscle. Anything less than this will not do anything. So what's that biological process that's associated with what I'm speaking of? What's it called? If we don't have, specifically in ultrasound, we have to heat the tissue to 40, 45 degrees centigrade. Or what's that known as? That biological principle? The Arndt-Schultz principle, right? In order to get a biological or a physiological response, we have to do what's necessary. If we do less, we get nothing. If we do more, we get something detrimental. Okay, so that, I didn't even see that up there. It's up there. I'm asking you guys, and you didn't even read it.
Nope, definitely didn't read it.
Professor, is that like saying minimal effective dose or not?
Well, if we don't have enough, it doesn't do anything. That's all. If we have too much, it may be detrimental, right? So if we have too much or too many contractions with the amount of time we selected, we may fatigue the muscle when our goal was to make it stronger.
Okay.
That's all. All right? Following? So pulse duration, time the current's on. We talked about 150 to 350 pulse duration, microseconds, right? Those are the units that we have in there. And time of one cycle to take place. Phase duration needs to be long enough for that action potential to occur. So, here it is. This is what I was talking about before. Here you have a line, horizontal and vertical line. And we have, this would be positive and this would be negative if we were looking at a net charge to develop. Okay, but we're not. If we have an AC current and it's symmetrical, we're not going to get any charge developed. So the phase duration, this is the interpulse interval, so it's the time between pulses. This is the pulse duration, the whole time that the current is on. And this is the phase duration. So the positive part is on this much and the negative part is on this much.
Everyone must wear a face mask at all times in all areas of the building. Everyone should observe social distancing, which is 6 feet apart. There should be no more than 2 people on an elevator at any one time. Everyone should wash their hands frequently, and if you feel ill, please stay home. Thank you for your cooperation.
Okay? So this is kind of self-explanatory if you just look at this picture, right? So this is the whole time that the pulse is on. This is a positive and negative polarity. Here's the phase of the positive side and the negative side, and this is between pulses. So you need to have this occur in order to have depolarization to occur. Okay. Phase, duration, pulse, it's just a picture. All right. Current types we talked about. We said that there was an AC current and a DC current. And an AC current, the electrons are constantly changing directions. So it's continuous. AC current is also, sometimes you'll see in some books, it's called a sinusoidal wave or a medium frequency waveform. It's good for edema, muscle spasm, spasticity reduction, pain. Continuous can also be delivered interrupted, so we can interrupt it, and if we deliver it interrupted in the form of bursts, that is known as Russian stimulation. So it's an AC medium frequency current that's interrupted.
With intervals, like the
Yes.
rest.
A DC current, DC facilitates what 3 things? Important. DC current facilitates wound healing, stimulation of denervated muscles, and also for iontophoresis. Right? So that's the three things DC current is used for. It's also known as galvanic stimulation. It's continuous, it can be continuous or interrupted, but you have a polarity, you have to choose a polarity. So either you choose a positive or a negative polarity. All right, depending on what you need it for. And remember I said we're going to use high volt pulse current. It used to be known as high volt galvanic current, but they changed the name. High volt pulse current, we will choose a polarity. A positive polarity or a negative polarity for wound healing. Iontophoresis, a positive or a negative electrode for delivery of drug. So we have to know what is the drug, what's the makeup of the drug, and what charge does it carry. If it carries a positive charge, then I use it under
Positive.
an anode, which is a positive electrode. Okay?
Right, diode's the negative, right?
If it's negative, I use it under a cathode. Right? And why is that? Because we want to propel it away from the electrode, and we want to propel it into the skin. You guys have seen it, iontophoresis, right? No? Never?
Not a heavy base.
Okay. We're going to try DC current. DC current is caustic. DC current can cause a burn, big time burn. We used to use low volt DC current when I first started years ago, and I'll share with you that I placed it on somebody's dorsiflexors. She was an MS patient. The therapist told me all the sensation was intact. Said you could use DC current on her. I placed it on dorsiflexors to do dorsiflexion. I know that it causes a burn, so I said to her, if you feel anything, if you feel any burning, you might feel a little tingling, but if you feel any burning at all, please let me know. I had been working with a patient next to her, and within it's about 2 minutes, I said to her, how do you feel? And she says, oh, it feels good. And I said, you know what, I'm going to check it anyway. And I took the electrode, I turned the machine off, looked under the electrode, she had bright red spots. Bright red. And then I said, you know what, I'm not going to use this anymore. I tried to put some ice on it, I tried to cool down the area and all. I just didn't like, because you could see the electrodes, especially distally. She came back 2 days later and had a hole in her leg.
Oh my God.
She had a hole. So she had a burn. She had an electrical burn from the DC current. And I said to her, when I asked you how it felt, you didn't tell me that it was burning, because I asked you specifically, and she said, oh, I just figured that was a good thing. The more I could take, the better it is. So I had we had to do an incident report. I had to have her write it down. I had to write it down, et cetera, et cetera. I had to keep her on my patient load for 6 months until it healed. So we didn't charge her, of course, and then I had to start treating her for a wound. She never sued me, or the facility, or the place, but she could have. But my concern was, I hope this poor woman doesn't lose this leg because of this wound. But you have to take this very seriously. It's electricity. Okay, especially a direct current. It can cause a burn. Okay, buffer electrodes help that, and everything that we have out there today is a lot different than it was, but be careful if you're using DC current. Okay? Pulsatile current can be unidirectional or bidirectional, so you could pulse the current also. You could pulse it in one direction, you could pulse it in 2 directions, either positive or negative. All right? The cathode, so the current flows from high to low, from a positive pole to a negative pole, positive pole being the anode, negative pole being the cathode. And the cathode is the site of depolarization, so that will make the nerve more excitable, right? So it depolarizes. So it's sometimes called the active electrode. And the cathode is a negative electrode. The anode is the site of hyperpolarization, and that is the positive electrode, okay? Anode positive, cathode negative. And you have to have both to complete a circuit. Okay? All right. So carrier frequencies, I don't have that yet. I have pulse frequencies. Carrier frequencies, low frequency currents, you can do biphasic. Biphasic meaning you have above and below, right? Or monophasic stays on one line. So monophasic, you choose a polarity. Biphasic, you have an AC current. Low frequency currents. Medium frequency currents are at 1,000 to 100,000 pulses per second. That's a medium frequency current, and that's interferential as well as Russian. And then high frequency currents are over 100,000 pulses per second. This you don't have to know. Nobody's ever going to ask you this. This is just, you could just say medium frequency current is interferential as well as Russian. All right, frequency, cycles occurring in 1 second. All right, so that's your frequency. Frequency, the unit for frequency is hertz, right? In an AC current, it says here, if it changes its directional flow 120 seconds, meaning that it goes above and below the line, how many cycles is it? 60, right? 60 cycles per second. And the waveform is that graphic representation that I told you that we could look at. So I might ask you to draw a waveform. So examples of some waveforms are biphasic symmetric. What does this mean? What is biphasic
They're the
symmetric?
same on both sides.
It's the same on both sides, the positive and the negative side. So is there a net charge accumulated in the tissues?
No.
No. No. It's canceled out. A biphasic asymmetric?
They're lopsided.
Yeah. And monophasic pulsed. Yeah. So you can imagine what they look like, and here they are. So here's an alternating current, right? Energy is in a positive and negative direction, and there's no net charge accumulated. It's the same. DC current, energy travels only in a positive or negative direction. So what's this? Is this positive or negative?
Positive.
Positive. Everybody knows that, right? Above the line is positive, below the line is negative. Okay. Well, monophasic, this is monophasic, one phase. Biphasic pulse, because it's pulsed, it's not on continuous, right? You can see this interpulse area between the pulses. This is a symmetric. This is a balanced asymmetric. The same amount of current here as here, but it's balanced. This is an unbalanced asymmetric pulse current. Right? You could just see by the pictures. It's not hard to look at this and understand it. But they're all the different current types out there. Yeah.
So for symmetric up there, that one's not, that's not interrupted, correct?
It's not what?
Interrupted?
No. No. It's not interrupted. Okay. So what is electricity? It's a stream of stream of electrons along a conductor, and the circuit, you need to have two electrodes to complete the circuit. And a closed circuit is when the electricity will flow without interruption, and an open circuit is when the electricity is broken. So the flow of the electricity is stopped. Can you think about when you might stop the flow of electricity on something you have at home? A light switch, right? You turn it on, you turn it off. So it's either on, it's flowing all the time, or it's not flowing all the time. But we could change it, or we can alter it, or we could alter the flow of the electrical current by using something known as a rheostat. Okay? And what is a rheostat? Something that you have at home. All right? You're having dinner with your girlfriend, your wife. You invited her, you cooked. Or your husband, or your boyfriend. You invited them, you cooked. Well, men are usually better cooks, right? So, all right, so you invited them, you're cooking something. What do? You either put candles on, you don't have any candles in the house. But you're sitting at the dining room table, and you have a dimmer switch, right? So a rheostat, or a dimmer switch, is something that will alter the flow of electrical current. All right? That's known as a rheostat. So it provides the resistance to current flow by changing the way the electricity is flowing. All right. Strength duration curve. Strength duration curve, what does it tell you from those of you who did it the other day?
What it takes to achieve a technique.
Well, we looked, and if you didn't look at it the other day, you should really look at it today. But we looked at nerve firing. We looked at what fires first. Yes? And this is really important because it also has to do with stimulation of specific nerve fibers and controlling pain also. So, if those of you who remember placing, you looked at the rheostat and the chronaxia, you don't have to know these words because they don't ask these anymore. But it's just a relationship between the amount of current and how long the current is on in order to get a specific nerve to fire. That's what we look for in the strength duration curve. So the rheobase is really the minimal current that's needed to excite the tissue, and the chronaxia is really how long the current is on. Okay, don't worry about those words. Important thing is, this would be the duration, this would be the intensity, or the current flow. All right. Nerves don't depolarize in the same order. So when you place the electrical stimulation on you the other day, some of you that use the TENS, and it said, describe what you feel. What did you feel? You did it, right, Steve? So what did you feel first? What did you feel?
Fuzzy, tingling,
Buzzing and tingling. So that's sensory.
then twitching,
Then you felt twitching. And then you felt
pain,
like a contraction.
or like muscle power.
And then you felt pain.
Pain, that's a thing.
Okay. So which nerve has the lowest threshold to fire? Sensory, motor, or nociceptor? Which nerve has the lowest threshold to fire? Sensory nerve. Sensory nerve has the lowest threshold to fire. What does sensory nerve stimulate as far as fibers are concerned?
Alpha, beta.
Mechanoreceptors. Mechanoreceptors. What fires next? You told me you get a contraction, right? So what kind of nerve is that? That's a motor nerve. So what is that stimulating?
Mechanoreceptors or?
Alpha motor neuron.
Motor neurons. The motor unit.
What's the question?
Question is, what do motor nerves stimulate? I'm sorry, not motor nerves.
Motor units.
Sensory nerves stimulate mechanoreceptors, right? So the mechanoreceptors fire. What fires when you stimulate a motor nerve?
Motor units.
Motor units, right? And then what fires when you keep turning the machine up and it hurts? Nociceptors. And what are the nociceptors? Hmm?
A delta
Alpha, delta,
and
and C
C.
Those.
A, delta, and C fibers. They fire last, right? So you have, so the location of the nerve, superficial nerves will depolarize first, but also the type of nerves. So a sensory nerve will fire first, has the lowest threshold, followed by a motor nerve, followed by a nociceptor. Okay, well, what does it require? Does it require a greater intensity or a greater pulse duration? Or a greater frequency?
Want to go intensity?
Okay. When we have, well, if we looked at the strength duration curve, if we just looked at this, we would say, well, as the duration got longer, or as we increased the pulse duration, we stimulated other nerves. We stimulated first the sensory nerve, then we stimulated a motor nerve. We left it on long enough, we stimulated a nociceptor. Isn't that what we talked about before?
It also
Yeah.
depends though, 'cause
But also, when we talk, that's the strength duration curve, but it's not the same. Because if you increase the duration and turn it up high enough, you'll eventually get a motor response. But if we want a motor response and a motor response only, we need to make sure that the frequency tetany is a basis. Tetany and twitch responses are a direct response, or directly related to the pulse frequency. Okay, not the pulse duration, but the pulse frequency. Directly related to the pulse frequency. Okay, so if we look at this, this is what the strength duration curve should look at. We have microseconds and milliseconds. What did I tell you before? If we have a denervated muscle, our pulse duration would have to be, we'd have to use something that had a pulse duration in milliseconds as opposed to microseconds. So we're looking at A beta, sensory, motor, and sharp pain. So A beta are the mechanoreceptors, aren't they? We talked about that a little while ago, I forget when, but we talked about A beta fibers. They're the mechanoreceptors. So they get stimulated when we have a higher frequency and a lower pulse rate. Just remember that for now. High frequency, low rate will stimulate A beta fibers.
Simulate what?
High frequency and low pulse rate will stimulate A beta fibers. A low frequency and a high duration will stimulate motor fibers. Okay? If you get nothing out of today's lecture, I hope you get that.
Okay.
All right?
Is that gonna be on the quiz on Wednesday?
So high frequency, low pulse rate, sensory. Right? Low frequency, high pulse rate, motor. Which do you think you'd use for acute pain?
You said low frequency, high duration.
Oh, high frequency.
High frequency, low duration, sensory.
Yeah, you wanna use it since.
Low frequency, high duration, motor. Which do you think you'd want for acute pain?
High frequency, low pulse rate.
High frequency, low pulse duration. Sensory response. So you want a sensory response for acute pain. For chronic pain, you want a motor response. So how are you going to set the machines for a motor response?
Low frequency, high pulse rate.
Low frequency, high pulse rate. You got it. That's it.
I hate modalities.
Don't hate modalities. Don't be a hater.
He just had to turn them on, and
No.
that's it.
I'm not hating.
Then you could be an aide for the rest of your life.
I can't do that.
I'm glad. Okay. So what affects tissue excitation? All right, AC versus DC current. I said that before. AC current you're going to use for something that is innervated. DC current is something that's not innervated. Tissue and fetus, the greatest flow will be through the tissues, providing the least resistance, right? There's also, when we talk about interferential, I'll have to talk to you about the carrier frequency of the generator, because that also has the larger frequency of 4,000 hertz, will provide less resistance, so you'll get greater current flow. That's why it's more comfortable. But we'll talk about that when we talk about interferential. As well as the electrode placement. Okay, because if you're going to place the electrode over trigger points or motor points, you're going to get a greater stimulation, right? Electrodes. What's the purpose of the electrode? Complete the circuit. So when we used an electrode the other day, that we didn't want any, I should save that for electrode size. Hold on. So it completes the circuit, interface between the electron and line of flow. It's the primary site of resistance to the current, so this is where we're going to place the electrode. There's different types of electrodes we could use. Metallic electrodes we could use sponges with. We could use paper towels that are wet. We could use carbon rubber, which we have little carbon rubbers, and we have self-adhesive. But and gel decreases the resistance between the electrode and the skin, so we could use gel. So if you have an old electrode and it starts to lose gel, then what happens? If you have an old electrode, these sticky electrodes, what happens?
Increase resistance?
So if you have this electrode that's this big that has the density of this you're receiving current flow throughout, what's going to happen as you start to lose gel on the electrodes? The current density will be uneven, right? So you're going to have a high concentration of electrical current flow on only part of that electrode. So what could happen as a result of the rest of the electrode not sticking to a patient, you can have a burn. Okay? You can have a burn. So electrode size will determine the current density. So the smaller the electrode, the greater the current intensity. The larger the electrode, the less the current density. So if we wanted, like we did the other day, for a combination of ultrasound and E-stim, what did we have to do with we had to have 2 electrodes because you have to have 2 to complete the circuit. So what did we have to do to the non-treating electrode? Increase the size. Because the larger, we didn't want the patient to feel anything under that larger electrode. So the current density will decrease as you increase the electrode. So good question that's always on the exam and always on the state board is what do you do if someone cannot take the amount of electricity that you're giving them or they find it uncomfortable? What would you do? Discontinue the treatment, have smaller electrodes, increase the size of the electrodes, or just tell the patient to come back when the resistance of the skin is not as great? C, increase the size of the electrode. Yes. Increase the size of the electrode. Okay. So electrode arrangements are based on current density, how close they are to one another, and what anatomical points you have the electrodes on. So remember I said if you have the electrode on a motor point or a trigger point, you're going to feel it greater. So here's current density. Amount of charge that we have per unit area. Oh, I wanted to see, yeah. Okay. Amount of charge per unit area has to be high enough in order to cause depolarization. Current density is greatest where the electrode meets the skin and decreases after that. So as it penetrates, it decreases current density. Okay, it's greatest at the skin electrode interface, current density. Okay, for the most part. We have a bipolar technique, equal current densities, equal effects under each electrode. So you have 2 electrodes, they're the same size, they're going to feel it the same way. Monopolar technique is what we used for combination stem, right? So we used the treating electrode, an active electrode, and remember we said we had to use an electrode that was greater in size because we wanted to increase the current density. So generally, I think your book might say twice, it has to be at least twice the size. I'm so used to saying 4 times the size because that's what they used to say. I don't think they're really going to ask you that, but you're going to have to know that the non-treating electrode is at least twice the size of the treating electrode. Okay? And that electrode is known as the dispersive pad or the dispersive electrode. So if I asked you what is the purpose of a dispersive electrode or dispersive pad, you'd have to say it completes the circuit, right, the electrical circuit. However, the patient shouldn't feel anything under it because the increased size of the electrode decreases the current intensity. Okay? Yes? Okay. And quadrupolar technique is 2 electrodes coming from 1 lead, and the leads are bifurcated, so they're split. So you have 1 lead bifurcated, and then you have 2 electrodes on each channel. So you could use 4 electrodes to treat a patient. All right, with a small TENS unit or with a larger TENS unit, the transcutaneous electrical nerve stimulator. All right, here's another thing that's important. The closer you place the electrodes, the more superficial the treatment area. The further apart, the deeper. Okay, so think about that if you were going to treat a quadricep. All right, the closer together. So if I wanted to increase knee extension, because somebody had an extensor lag, what position would I put them in? What parameters would I use as far as frequency and pulse duration? Andrew, I'm asking you. What frequency, pulse duration, what position, what kind of a duty cycle, and where would I place them? Hmm?
Okay, so you place those.
They have an extensor lag. What does that mean to you?
So that means that they are lacking extension.
They're lacking extension. So they have an extensor lag of 30 degrees.
Okay. So you would go low frequency, high duration.
So where would you place the electrodes, and what size electrodes would you use? Would you use like the size of a quarter, or would you use
Bigger
size of a dime, or would you use the size of a tennis ball?
tennis ball.
Tennis ball, okay. And where would you put them?
Probably one on the VMO and one a little higher up, like rectus femoris.
You put it on the VMO and the rectus. You guys agree? You should. Yeah, okay. And what frequency, what pulse duration, and what duty cycle?
Low frequency, high duration.
All right, we want a motor response, right? But we're not treating for pain. We're treating for muscle re-education. So what frequency do we need to use to get a sustained muscle contraction?
Low. High. There was low frequency, high duration.
A sustained muscle contraction.
Oh, high.
Okay, those parameters I should say, when I said high and low, low and high, that's for pain and edema. Okay, muscle re-education, or yes. Muscle, you're gonna get a muscle contraction at that low frequency, yes you are.
Right.
Yes you are. However, it's for a different, it stimulates fibers differently so that we control pain or edema. For muscle re-education, what do we need? Do we need tetany?
Yeah.
Okay,
Yes.
so what frequency do we use for tetany?
High frequency.
High frequency?
50 or higher.
50 or higher? You guys listening at the beginning of this lecture?
30
What
to 50.
frequency for twitch response, what was the frequency?
10 to 20 and 30 to 50 for
10 to 20. And what was it for tetany?
50 or less.
50. Okay, so we would have to set it for a frequency of like 35 to 50. Generally, they're in the machine already. What pulse duration would I need? If I told you my pulse duration went from 150 to 350 microseconds, what pulse duration would you choose?
Closer to 350. Closer to 350.
Oh, so between 250 and 350. Yeah. That's, you could pretty much guarantee that all the time. Pulse duration of 150 to 250 for upper extremity, pulse duration for 250 to 350 for lower extremity. Pulse frequency of 35 to 50 will give you tetany, and a pulse frequency of 10 to 20 will give you twitch. All right? High rate and low width is for pain and edema, okay? Because of the stimulation of the nociceptors or stimulation, and we haven't really talked about that because there's a top-down and a bottom-up approach when we talk about pain. Either we gate it from the periphery or we gate it from endorphin release. We haven't really talked about that. So yes, I commend you on listening to what I said. It's just that we haven't got that far yet. Okay? So when we want a motor response, not a motor response, but when we want a motor contraction. When we want a sustained contraction, we need a frequency of at least 35 to 50 hertz. Okay? Always remember that. A frequency of 35 to 50 hertz will give you a sustained muscle contraction. Anything over this, left on for a long period of time, will give you muscle fatigue. Yes?
Before you were talking about pulse rate, is that the same thing as pulse rate?
Yes. Pulse rate and pulse frequency are used interchangeably. Pulse width and pulse duration are used interchangeably.
Pulse rate and pulse frequency are the same thing.
Yes. Yes.
How much of this stuff is on this Wednesday quiz?
Not much.
Professor in the beginning.
No, not much. There's actually, is there anything on this?
I'm gonna lay down.
There's nothing on this Wednesday quiz from today.
Are you sure?
Yes. Well, what does that mean? Does that mean that you can't, that you go home and not look at this until the weekend?
Till Thursday.
No, you have to know this, yes.
So at the beginning of the lecture, you said that 50 plus is 10, and now you're stating that.
No, 35 to 50, a pulse frequency of 35 to 50 will give you 10. Yes.
And 50 plus will fatigue the muscle.
Well, if you go over like 80, yeah.
I just wanted to-
Okay?
So the stuff that they're learning now will be on it, but the stuff that you talk about that might have relationship piece there
Right.
could be on.
Right.
So the stuff we did in lab last Wednesday, we did this crane duration curve, we did the TET-E, the switch. That
So
stuff
what
we-
fires first, you should
that stuff
know,
you should know.
okay? Yeah. All right, I think there's 3 or 4 chapters in your book that I told you guys to start reading. You gotta read them again and again, because electrical stimulation is not easy. And Professor D'Onofrio and I were talking about this, when we went to school, they didn't even explain it. They just said, here it is, and this is what you use it for, and blah, blah, blah. Right?
Yeah.
So we're trying to explain to you to try to make it, I think, a little bit more understandable. All right? So we know, if you place the electrodes closer together, place the electrodes further apart. What Andrew says, you take an electrode, place it on the rectus femoris and the VMO. Why do we use those 2 parameters? Why? Those 2 muscles area. To extend the knee, right? And what does the VMO do? It works in the last 15 to 30 degrees of knee extension. The rectus femoris is a 2-joint muscle in the thigh, the only 2-joint muscle in the thigh, right? Joe, what's the rectus femoris and VMO innervated by?
Damn it. Oh, the femoral?
Which one? Femoral nerve, yeah. Okay. All right, so areas with decreased resistance, motor points, predictably located. You can look in the back of any modality book and it'll show you where a motor point is. Okay, generally in the middle of the muscle, closest to the skin. Trigger points, hypersensitive muscle spasm. Remember I said trigger points usually refer to, pain usually refer to other areas, but there's a trigger point. So a trigger point is also a stimulation. An acupuncture point has decreased electrical resistance too. An good acupuncture point, a lot of times they put 10 units on, is right here. It's a Hoku point in the web space. That's an acupuncture point. And any area of trauma. Okay, so they're good stimulation points. So what will happen? Excitation, the electrode placement, where you place the electrode is going to determine how you excite the tissue. Electrodes are close together, what's going to happen? Current flows superficially, further apart, we get deeper penetration. As the electrode size decreases, you get an increase in current density. As the electrode size increases, you get a decrease in current density, and we want to make sure that we maintain our electrodes. Okay, and you can use carbon, you can use metal, you can use a wet towel, you could use a sponge, or you could use buffered electrodes that come, but they're very expensive. How much does anybody know? What do those electrodes cost? They're very expensive. Yeah. And don't ever use one electrode on somebody and then take it off. A lot of times you see that in clinics. Yeah, they'll use different electrodes for different people. Do not do that. You do that? Andrew. Shame on you, you better not do that anymore. Okay. All right, I think we'll finish here.
Yes.
What do you mean, good?
Thank God.
Good.
This was a simple... Wasn't it?
What are you talking about, simple?
Didn't I explain it? I explained it to you.
You explained it very well.
We explained it well. This stuff just sucks.
I'm just trying to recover from this easy.
All right. So those of you who have not used a small TENS unit and looked at the difference between sensory and motor and nociceptive input, and I encourage you to play with the machine while it's on, all right? I mean, unless you're really fearful of the electrical current, as long as you have enough gel on these electrodes or enough water, nothing's going to happen with these little units, okay? But I do want you to feel the difference between sensory, motor, and nociceptive. And I think maybe we'll do maybe we'll play with some biphasic and free modulator or something today.
Not everybody did the straight range
Yeah.
curve,
Yeah.
we can start that.
Okay.
But how is these